Hello, Abe Morgentaler here. I'm going to summarize now the events of the second day of the annual meeting of the Androgen Society. This was testosterone, testosterone all the time. And if you're interested, you should definitely be looking into the Androgen Society at androgensociety.org. We also have a meeting next year. We expect it to be in person, April 21st to 23rd in Orlando, Florida, and we hope to see you there. The Androgen Society really is designed to bring together healthcare professionals from all the different fields, urology, endocrinology, public health, etc., and to have one meeting where we can all discuss the latest clinical and research information. So the second day really had some incredible material. We have some exciting information now about testosterone and type 2 diabetes. Gary Wittert, the lead investigator from the T4DM study in Australia, presented the results of his study. Hugh Jones, a clinician investigator from the UK, has been doing a lot of work with men with diabetes and testosterone, and he spoke about testosterone and glycemic control. And then Farid Saad presented remarkable data about the possibility of testosterone actually leading to remission of diabetes. The T4DM study enrolled 1,007 men, 856 completed. It was a 2-year study, and they're included in the data analysis, making this, by the way, the largest controlled study with testosterone. Men were ages 50 to 74, and they all needed to have an abnormal glucose tolerance test. They had low or low normal testosterone levels defined as less than 14 nanomoles per liter. In US units, that's approximately 400 nanograms per deciliter. And it was a 2-year study where they got either testosterone undecanoate injections or placebo. And everybody had to be involved with what used to be called Weight Watchers, now WW, for behavioral intervention. So exercise, diet, nutrition, etc. And you can only imagine how much work it is to do such a large study for 2 years, both with the behavioral component, the Weight Watchers part, and with a treatment arm. And I think the top line here is the main result, which is that at the end of the 2 years, the number of individuals, or the percentage of individuals who actually had frank type 2 diabetes, was 12.4% amongst those who received testosterone, and 21.1% in men who received placebo, a major difference. If we look at the bottom left, we look at preventing type 2 diabetes. These are men amongst those who had prediabetes. Remember, everybody needed to have an abnormal glucose tolerance test. We had 7.6% of the group went on to type 2 diabetes in the testosterone arm, compared to 14.9% in men who got placebo, just a little bit more than half, reduced by half with the testosterone. And amongst those where we're reversing type 2 diabetes, if we include the men who not only had an abnormal glucose tolerance test, but also had criteria for diabetes itself, the testosterone group, everybody went down, because remember, they've got an interventional arm here too with behavioral treatment. 45% of the placebo group had it, if they had it at baseline, and 31%, so reduced even further in the testosterone group. And if we look at secondary outcomes, testosterone did a variety of things that are beneficial compared to placebo, including greater decrease in fasting glucose, waist circumference improved, total fat mass went down, muscle mass went up. a whole host of things. Does testosterone improve glycemic control? This is from Hugh Jones. And, amongst the conclusions of his review here is that insulin resistance is the most important biochemical defect in prediabetes and diabetes. And that testosterone replacement or testosterone therapy has been shown in a majority of randomized controlled trials to improve insulin resistance. And at the bottom, any benefit on glycemic control is important for reduction of the complications of diabetes, including mortality. So testosterone may be something we really want to be seriously considering in men with diabetes. This is a presentation from Farid Saad on evidence that testosterone could lead to remission of diabetes. And this is a slide based on a registry data in men who had both testosterone deficiency or hypogonadism and type 2 diabetes. And they had 178 men who received testosterone and a control group of those in the same practice who did not. And if you look here, I think the most interesting thing is on the left of this bar graph. None of the men who didn't receive testosterone had remission of type 2 diabetes. And remission here means they have normal glycemic parameters without medication. They're essentially cured. And amongst the group that got testosterone, 34.3% of them actually had remission. Just astonishing. We had a talk by Sudarshan Ramachandran from the UK about testosterone anemia and hematocrit. Testosterone is involved in erythropoiesis. And one of the reasons that men have a higher hematocrit on average than women is postulated to be due to testosterone. And certainly when I see patients in the office who present for the first time with testosterone deficiency, it is not at all unusual for them to have a hematocrit that is in maybe normal, but the lower part of the normal range. And the testosterone trials, a large randomized controlled trial with primary results published in 2016 in the New England Journal of Medicine, had a sub-trial involving men with unexplained anemia. And the group that got testosterone compared with placebo showed resolution of anemia in many of those men. We heard a talk by Mary Samplaski from Los Angeles on COVID and testosterone. The quality of data around this is not great, but I think the bottom line is that individuals who are hospitalized, men who are hospitalized with COVID, the lower the testosterone, the greater the risk of them going on to more severe disease, either death or ICU with a ventilator. It remains an open question whether or not testosterone therapy may actually be beneficial in individuals with severe COVID. We had a panel discussion on testosterone and prostate cancer where a number of clinical scenarios were presented to our experts, and it included issues like testosterone therapy in men with an elevated PSA but a negative prostate needle biopsy, and also the use of testosterone therapy in men on active surveillance for intermediate risk Gleason score. Mohit Khera gave a presentation on testosterone therapy and prostate cancer, and he had a lot to say. And here are some of his conclusions. There's currently no evidence that testosterone therapy promotes the initiation of prostate cancer. Early data has not demonstrated any increased risk of prostate cancer progression in men on active surveillance. Low testosterone may serve as an independent risk factor for prostate cancer progression in men on active surveillance. And we have some very provocative new data that there may be a therapeutic and or protective role of testosterone therapy against prostate cancer. We had a session on testosterone in women with Sharon Parish and Leah Millheiser. This is a slide from Dr. Parish. Key points in talking about some of the new guidelines that includes that transdermal testosterone is moderately effective for HSDD, hypoactive sexual desire disorder in women. The goal is to maintain total testosterone in the physiological premenopausal range. And if there are no approved products of testosterone for women, I don't believe anywhere in the world, but certainly not in the US. And so one of the ways to go around managing this is to use 1/10 of the standard male dose of transdermal testosterone. Some conclusions from Dr. Millheiser about androgens and libido is that testosterone therapy exerts a beneficial effect on sexual function, including increases of an average of 1 satisfying sexual event per month. Obviously, that frequency is either significant or not significant, depending on how often one is having sexual activity. Use of testosterone at physiological levels for a premenopausal woman is associated with mild increases in acne and body or facial hair growth in some women, and that safety data is limited to 2 years. Daniel Kelly from Sheffield in the UK spoke on testosterone and atherosclerosis, and has identified 5 areas where testosterone may influence the development of atherosclerosis, with a general sense that the weight of evidence suggests that testosterone is beneficial in terms of atherosclerosis. And those 5 areas include monocyte activation, endothelial activation, plaque stability, macrophage activation or inflammation, and macrophage lipid processing. Abdul Traish spoke about androgens and the immune system. This is one of his slides showing how testosterone with or without association with the androgen receptor has effects on a variety of the cells involved in our immune response. As a general comment, testosterone therapy or higher levels of testosterone have positive effects on the immune response. And there's some evidence that some immunological disorders such as psoriasis, actually that outbreaks of this are reduced in individuals receiving testosterone therapy. I think that is it for day 2. So I'm going to stop here, and I hope to see you again for a summary of day 3.